Hey guys, welcome back to my channel, The ENT Resident. Today I'll be discussing about acute otitis media, also known as acute suppurative otitis media. Now this is a very important topic from not only the perspective of theory exams where you can get a lot of short notes from this topic, as well as from the perspective of clinical practice, because a lot of infants, a lot of young children come with the case of acute otitis media to you. And if you want to purchase my notes, now I have added links in the description. Okay, so let's get started. So, first of all, what is acute otitis media? Now, this is basically the inflammation of the middle ear cleft. Now, acute inflammation of the middle ear cleft, which is of rapid onset and it is infective in origin. And this is associated with usually a middle ear effusion and a varied collection of clinical signs and symptoms. We also know this as acute suppurative otitis media. Now, I mentioned that this is inflammation of the middle ear cleft. Now, what are the structures of the middle ear cleft? The middle ear cleft consists of the middle ear cavity, attic, adidas, antrum, and mastoid air cells. These five things together form the middle ear cleft. So, acute otitis media is basically inflammation of the middle ear cleft, which is of very rapid onset and infective origin. Now that we know what acute otitis media is, let us briefly describe what are the types of acute otitis media. So, there are four subgroups of acute otitis media. This is on the basis of the occurrence of number of episodes of acute otitis media. So the first group is sporadic. In the sporadic acute otitis media, this is usually a very infrequent type, and these are very isolated events. And usually it occurs with the upper respiratory tract infection. So that is sporadic acute otitis media. Second is resistant acute otitis media, when all the signs and symptoms persist beyond 3 to 5 days of antibiotic treatment. That is when you call this as resistant otitic media, resistant acute otitic media. Third type is persistent acute otitis media, where you see a persistence or recurrence of symptoms and signs within 6 days of finishing of a course of an antibiotic. So in resistant acute otitis media, you see that the even despite treatment of 3 to 5 days of antibiotic, the symptoms do not resolve and it persists. Whereas persistent acute otitis media is basically when there is been 6 days of finishing the course of antibiotics and we see a persistence or a recurrence of symptoms and signs. And last of all is recurrent acute otitis media, where either you see 3 or more episodes within a 6-month period or at least 4 to 6 episodes within a 12-month period. So these are the four subgroups of acute otitis media. Next, let's move on to in what age group is this disease very common in. As I said before, this is a disease of infants and young children. The incidence has been seen to be highest in the first year of life and more specifically in the second 6 months of life. And as the age increases, the incidence of acute otitis media starts reducing. Next, let's understand what is the cause of acute otitis media. Now, usually this disease follows a viral infection of the upper respiratory tract. But soon after the viral infection occurs, usually pyogenic organisms invade the middle ear. So that is the main cause of acute otitis media. So first let's talk about the viruses. Now, what is the most common virus which causes acute otitis media? It is respiratory syncytial virus. And other than respiratory syncytial virus, the other viruses which can cause this are influenza A virus, parainfluenza virus, human rhinovirus, and adenovirus. Now, when there is a viral infection at a cellular level, you see that there is a release of multiple inflammatory mediators from the cells within the nasopharynx. And as a result of this, the ciliated epithelial cell numbers start to decline. There is an increase in mucus production in the eustachian tube, and this leads to a negative middle ear pressure. Now, as soon as the negative middle ear pressure develops, that predisposes to development of acute otitis media. So, this is about the viral part. Now, let's talk about bacteria, the pyogenic organisms that invade the middle ear cleft. What is the most common bacteria which causes acute otitis media? It is Streptococcus pneumoniae. And the second most common bacteria which causes is known as Haemophilus influenzae. This is a very common MCQ question asked in NEET PG exams or any entrance exams as well. So these are the two most common bacteria which causes acute otitis media. Now there are other ones as well known as Moraxella catarrhalis, Streptococcus pyogenes, Staphylococcus aureus and Pseudomonas aeruginosa. There's another most common bacteria we need to know which causes recurrent or persistent acute otitis media. Now this bacteria is drug resistant pneumococcus. Now, why is this the most common bacteria? Why is it able to resist drug? Because here the penicillin resistance develops from a decreased penicillin binding protein on the bacterial cell wall. This reduces the affinity of the penicillin related drugs to this organism, as a result of which this drug resistant pneumococcus is the most common bacteria which has been isolated in cases of recurrent or persistent AOM. So that was about the basic causes. We have spoken about the viruses, the most common being respiratory syncytial virus, and the most common bacteria is Streptococcus pneumoniae. The second most common bacteria is Haemophilus influenzae, and the most common bacteria causing recurrent or persistent AOM is drug-resistant pneumococcus. Now let's talk about a few syndromes that are seen to be associated with acute otitis media, which means what are the syndromes in which it has been seen that there is a higher incidence of acute otitis media. The most common one is Turner syndrome, Down syndrome, cleft palate, and there has also been a direct association between iron deficiency anemia, degree of the anemia, and frequency of acute otitis media. So, this was all about the infective aspect of acute otitis media. Now, there are also certain environmental factors which can lead to an increased incidence of acute otitis media. So there is a higher incidence usually following seasonal URTIs in the winter months. It has also been seen that breastfeeding for 3 months is seen to be a protective mechanism. Third, a higher incidence is seen in poor socioeconomic status, mainly due to poor housing and overcrowding. And lastly, it has also been seen to be associated with passive smoke exposure from parental smoking. So, this is all about the etiology of acute otitis media. Now, let's try to understand what are the routes of infection in acute otitis media. There are 3 main routes. Now, the first route is via the eustachian tube, and this is the most common route that has been seen. Usually, what happens here is infection starts traveling by the lumen of the eustachian tube or along the subepithelial peritubal lymphatics. So, this is the most common route. So, there is one question that you need to know: why are infants and young children more prone to develop acute otitis media? There's a reason for it. This is because the eustachian tube in this age group is actually shorter, wider, and more horizontal. And that is the reason why it has been seen that infants and young children are more susceptible to developing acute otitis media. This is also the reason why, when you are breastfeeding or bottle feeding an infant in a more horizontal position, this may force fluids up the tube. and this can eventually lead to acute otitis media. So, when you're feeding an infant, you're supposed to keep the infant propped with the head at a higher level. Even swimming and diving can also force water through the eustachian tube into the middle ear. So, this is about the first route. Next, let's talk about the second route, which is via the external auditory canal. Now, here what happens, the pathogen can gain entry into the middle ear through either a tympanic membrane perforation or there can be a ventilation tube present. So, this is been seen to be most commonly associated with water exposure usually. So, this is the second route via which the acute otitis media develops. And the third route is the blood-borne route or the hematogenous route, which is actually a very, very uncommon route. So these are the three routes of infection. This is also again a very important Viva question asked to you. Next, let's talk about what are the risk factors or the predisposing factors towards developing acute otitis media. The first cause is the recurrent attacks of URTI and common cold. Next, in exanthematous fevers like measles, diphtheria, whooping cough, in recurrent cases of tonsillitis, adenoiditis, chronic rhinitis, and sinusitis, in cases of nasal allergy, tumors of nasopharynx, cleft palate and palatal palsy, in cases of barotrauma, where the atmospheric pressure changes during flying and deep diving, and this can affect the eustachian tube functioning. Even in cases of low levels of IgG2, which means the patient is immunodeficient, these cases are actually more at risk to developing acute otitis media. Even in poor socioeconomic status, where we see a lot of overcrowding and hygiene not being maintained. So all of these are things that little things that all predispose the patient to developing acute otitis media. Next, let's talk about pathology. Now, the acute otitis media develops through 5 stages. Now, first, let's know what are the stages. The first stage is the stage of tubal occlusion. After the stage of tubal occlusion comes the stage of presuppuration. Then comes the stage of suppuration. Then comes the stage of resolution. And the fifth stage is a stage known as stage of complication, where instead of resolving, the condition becomes worse and there are complications seen. So these are the 5 stages in acute otitis media. And each of this stage is characterized by a little bit different symptoms and signs which are very specific to it. Now let's start discussing each stage one by one. So the first stage is stage of tubal occlusion. So following a upper respiratory tract infection, what happens is there is edema and hyperemia of the nasopharyngeal end of the eustachian tube. This leads to a blockage of the eustachian tube, and as the eustachian tube gets blocked, there is absorption of air and a negative intratympanic pressure develops. And because of this negative intratympanic pressure, it leads to the retraction of tympanic membrane with some effusion in the middle ear. Now, the symptoms we'll see in this case is the child will come with a mild deafness. However, this will not be the presenting complaint because usually children are not aware of mild levels of deafness. The patient can also complain of ear fullness and ear pain, but the important thing to remember is at this stage there is no fever. And the signs seen are that of a retracted tympanic membrane, where we see a foreshortened handle of malleus. If you can see in the image over here, this is a foreshortened handle of malleus. There is a prominent lateral process of malleus, and you can see that there is a loss of the light reflex in the antero-inferior quadrant. So these are the signs of retracted TM. And when you do a tuning fork test, you will see a conductive hearing loss. Next, we move on to the stage of presuppuration. Now, when the tubal occlusion has been prolonged for a long period of time, this leads to invasion of the tympanic cavity by pyogenic organisms, the most common one being Streptococcus pneumoniae, and the second most common one being Haemophilus influenzae. And as they invade the tympanic cavity, it leads to mucosal hyperemia, and this leads to formation of inflammatory exudate in the middle ear. Now, at this stage, the patient will complain of a marked throbbing ear pain, and this will awaken the child at night. The patient will also have high fever and restlessness. There may be a bubbling sound coming from the ear. There will also be deafness in the patient, but however, this will not get noticed by the child because of the severe ear pain that he or she is experiencing. Now, when you come to signs, first of all, what happens is the pars tensa gets congested, and there is a typical appearance we see in this stage, which is known as the cartwheel appearance of the tympanic membrane. If you see in the image over here, this is the cartwheel appearance of tympanic membrane, where we see a leash of blood vessels which appear along the handle of the malleus and at the periphery of the TM, giving it a cartwheel appearance. So this is the handle of malleus, this is a leash of blood vessels, and you can see also how it is coming up as a leash of blood vessels from the periphery of the tympanic membrane, and this gives it a cartwheel appearance. And later on, the complete tympanic membrane, including the pars flaccida, gets completely congested and becomes red. And again, tuning fork test will be showing a conductive hearing loss. Third stage is the stage of suppuration, when there is a starting of the formation of pus in the middle ear and the mastoid air cells. And at this point, the tympanic membrane starts bulging to the point of rupture. Now, at this point, the patient will come with your symptoms of excruciating, unbearable ear pain, increasing levels of deafness, and there will be other constitutional symptoms because of absorption of toxins, which will include rising fever, vomiting, and in extreme stages, diarrhea and convulsions. And if you see the image over here, you will see that the tympanic membrane appears very congested, reddish, and bulging to the point of rupture. You can see the formation of pus in the middle ear cavity. And there will be loss of all landmarks on the tympanic membrane. The handle of malleus will get engulfed by the swollen tympanic membrane. Sometimes you can see a nipple-like protrusion with a yellow spot on the tympanic membrane, at the site of which the rupture is imminent. And you'll also find tenderness in the mastoid, and X-ray mastoid conducted at this time will show clouding of the air cells. So this is a very typical picture of the stage of suppuration, where the tympanic membrane is red, congested, and bulging to the point of rupture. That leads us to the fourth stage, which is known as the stage of resolution. At this stage, the tympanic membrane ruptures and it leads to release of the pus, and this reduces the symptoms and the inflammatory process starts to resolve. However, the tympanic membrane always doesn't need to rupture. If proper treatment has been started early or the infection was mild, resolution will start even before the rupture of tympanic membrane happens. So in this stage, usually the symptoms are blood-tinged ear discharge, which later becomes purulent, and the ear pain and fever subsides and the child starts to feel better. Now, the ESC becomes filled with blood-tinged or mucopurulent discharge, which may be pulsatile. Now there's an important sign that we see here, which is known as the lighthouse sign. So in lighthouse sign, what we see is there is pus coming out under pressure and synchronizing with each arterial dilatation of the heartbeat. And we also see a perforation of the tympanic membrane. You see in the image over here, there is a perforation in the pars tensa, and most commonly this occurs in the antero-inferior quadrant. So this is the stage of resolution. Now let's move on to the fifth stage, which may or may not happen, which is the stage of complication. So we see that when the virulence of the organism is high or the resistance of the patient is poor, in that case, resolution may not take place and the disease can spread beyond the confines of the middle ear. And this can lead to a range of complications which include acute mastoiditis, subperiosteal abscess, facial paralysis, and etc. We'll come to complications in a later part. So this completes the stages of acute otitis media. Now let's just summarize first what are the clinical features we have seen in a case of acute otitis media. The common symptoms are rapid onset of otalgia, hearing loss, which is usually conductive in nature, otorrhea, which can be mucopurulent or even blood-stained, fever, excessive crying, irritability, coryzal symptoms, vomiting, and poor feeding. And acute otitis media mostly develops 3 to 4 days after the onset of coryzal symptoms. And otalgia has been seen to settle within 24 hours in two-thirds of children without any treatment. Symptomatic relief is obtained without treatment in about 88% cases by day 4 to day 7. Now, coming to the signs, you can see in the image over here, this is how a normal tympanic membrane looks like. And on the right side, what you see is how a acute otitis media tympanic membrane looks like. The tympanic membrane gets very congested and reddish in color. And we see a cartwheel-like appearance in the stage of pre-suppuration. In the stage of suppuration, we see a bulging tympanic membrane. And in the stage of resolution, we see a perforation in the tympanic membrane, usually in the antero-inferior quadrant, and also we can see lighthouse sign in this case. So this is about the clinical features. Now coming to diagnosis. So a diagnosis of acute otitis media is purely a clinical diagnosis on the basis of the history of the patient and what symptoms and signs are found. So usually it is seen that there is a history of crescendo of otalgia. Crescendo of otalgia meaning increasing ear pain in succession. The ear pain keeps getting worse. In a coryzal child, followed by rapid symptomatic relief associated with a tympanic membrane perforation and associated blood-stained otorrhea. Next, let's talk about investigations that you perform in an acute otitis media. Usually, we do not need to perform any investigations. However, some of the investigations which may be important in specific cases is, first of all, tests of hearing. Any audiological test will show that the patient has conductive hearing loss. Second is CT temporal bone. A CT scan of the temporal bone is indicated only in cases of refractory mastoiditis, and in this case, the findings will be that of clouding of air cells and pressure necrosis leading to coalescent mastoiditis. We can also see demineralization of the air cell septa, which is a key radiographic sign of mastoid as osteitis. Third investigation is a bacteriological examination where the ear discharge is sent for culture and sensitivity to find out what is the type of causative organism and which antibiotic is this organism sensitive to. This is about the investigations part. Now let's move on to treatment. Now, when we talk about treatment, it can be divided into, first of all, a conservative treatment where we give analgesics and antipyretics. Usually, the children benefit from these simple medications. Paracetamol and ibuprofen over here are the most common medications which are used. Now, when conservative management does not work and the patient is getting worse, in that case, the mainstay of treatment becomes antibiotics. So, antibiotics are given if the symptoms are worsening or they are persisting even after 3 to 4 days. We'll talk a little bit more about antibiotics after this. The third treatment is a decongestant nasal drops, and this is usually given to relieve the eustachian tube edema. It helps in relieving the eustachian tube edema and it promotes ventilation of the middle ear. So the drops that are used over here can be ephedrine, which is 1% in adults and 0.5% in children, oxymetazoline, and xylometazoline. These are the common nasal decongestant drops which are used. Fourth is oral decongestants. Sometimes oral decongestants like pseudoephedrine can be given to children who are very difficult to administer nasal drops to. Fifth is oral toileting. If you see that discharge is present in the ear, the discharge is usually sucked out and can be mopped dry with the help of a sterile cotton. And last of all is myringotomy, where you incise the TM to evacuate the pus. So let's talk a little bit more about the antibiotics and myringotomy. So, antibiotics are prescribed when symptoms worsen or persist after 3 to 4 days. So, indication of antibiotics are when the patient is under 6 months of age, when the patient is under 2 years of age with recurrent episode, failure to improve after 2 days of waiting, more severe symptoms like pyrexia, vomiting, signs of complication, all high risk children, which includes Down syndrome, craniofacial abnormalities, congenital inner ear abnormalities, and immunodeficiencies, failure to improve after 2 to 3 days of treatment, and that time you should change the antibiotic. And lastly, cases of bilateral acute otitis media, recurrent acute otitis media, or tympanic membrane perforation. Now, what antibiotic is commonly used? There is a 5-day course of antibiotic given, or the antibiotic can also be given till the tympanic membrane becomes normal and the hearing is restored. The antibiotic of choice here is amoxicillin at a dosage of 80 mg per kilogram per day. In cases of drug resistant pneumococci, however, you need to use erythromycin or clarithromycin. And in cases of persistent or resistant acute otitis media, where you suspect a beta lactamase producing organism, in that case, the combinations used are amoxicillin clavulinate, cefuroxime axetil given orally, or ceftriaxone given intramuscularly. At any point, if you discontinue the usage of medication early due to the relief of earache or fever, or the treatment has been given in inadequate doses, it can lead to secretory otitis media and a residual hearing loss. Next, let's talk about myringotomy. What are the cases in which myringotomy is done? The indications are when the tympanic membrane is bulging and there is acute pain present, when there is an incomplete resolution despite antibiotic treatment and the tympanic membrane remains full with persistent conductive hearing loss. Third is when there is a persistent effusion beyond 12 weeks. Fourth, when you see a complication or even suspect that a complication might be present. And fifth is when there is microbiology strongly required. So, if we had to look at this table, a patient presents with you with acute otitis media. First, you ascertain is it with complication or without complication. If it is without complication, the first line of antibiotics, which is amoxicillin, is given, and you check for resolving of symptoms. If the symptoms resolve within 2 to 3 days, you recheck up after 4 to 6 weeks and see if there is a middle ear effusion. If middle ear effusion is present, you treat it. If it is absent, no follow up required. However, even after first line of antibiotics, if the symptoms do not resolve after 2 to 3 days, second line of antibiotics are used, like amoxicillin plus clavulinate combination or cephalosporins. And even in this case, if the symptoms do not resolve, we do a tympanocentesis and send the pus for culture sensitivity and treat the patient accordingly. For a case of complicated acute otitis media, we do a tympanocentesis, send pus for culture sensitivity, and treat accordingly. Next, we are going to talk about recurrent acute otitis media and how will we manage this. So, there are a few things you can keep in mind. First of all, is in these cases, you can try to reduce the risk factors. And this can be via reducing exposure to other children in a daycare setting, sitting a child semi upright if bottle fed, restricting the use of pacifiers, and avoid exposure to passive smoking. Secondly, antibiotic prophylaxis can be given where we give a single daily dose of amoxicillin 20 mg per kilogram for 3 to 6 months to prevent recurrent attacks. Third is xylitol, which is a sweetener, artificial sweetener that inhibits it is a sweetener that inhibits the pneumococcal growth and attachment of pneumococci and Haemophilus to the nasopharyngeal cells. This is usually administered via chewing gum or syrup. Fourth is zinc. Zinc is a micronutrient which is very essential for immune function and resistance to infections. Fifth is vaccination against certain diseases. So, in terms of viruses, we have the influenza A vaccination, and in terms of bacteria, polysaccharide conjugated vaccine against the Haemophilus influenzae type B. And the introduction of PCV7 into the childhood vaccination schedule has also reduced the burden of pneumococcal diseases. Last of all is surgical prophylaxis, where we insert a tympanostomy tube. This is done in recurrent and chronic cases where the ventilation of the middle ear is provided by inserting a grommet through the tympanic membrane. Last of all, let's discuss a few more things, which are first one is the outcomes of acute otitis media. So, when a case of acute otitis media comes to you, what are the possible scenarios that can happen? First is it can resolve rapidly with or without antibiotics. Second, it can prove to be resistant to first line antibiotics. Third, it can persist or recur shortly after a course of antibiotic. Fourth is it can subsequently reoccur again. Fifth, it can lead to effusion in the middle ear and a conductive hearing loss. And sixth, it can lead to a tympanic membrane perforation or any other complications. That brings us to discussing about the complications of acute otitis media. This is a topic that I'll discuss in a separate video, which I'll put out next. But briefly, if we had to know what are the complications, we can classify the complications of acute otitis media into extracranial and intracranial. And the most common complication here is a tympanic membrane perforation, which we see in about 1 to 10% cases. Other than that, the other extracranial complications are acute mastoiditis, petrositis, facial nerve palsy, and labyrinthitis. And intracranial complications can be meningitis, extradural abscess, subdural empyema, sigmoid sinus thrombosis, focal otitic encephalitis, brain abscess, or otitic hydrocephalus. Lastly, let's discuss what is the differential diagnosis of acute otitis media. It can be a pain that has been referred from tonsillitis, teething, temporomandibular joint disorders, or a result of uncomplicated upper respiratory tract infections. A diagnostic confusion is also seen with cases of acute mastoiditis, otitis media with effusion, otitis externa, trauma, Ramsay-Hunt syndrome, and bullous meningitis. And very rarely, AOM is seen to be the first indication of serious underlying disease like Wegener's granulomatosis or leukemia. Little bit, small tiny tidbit to know here is there is a variant of acute otitis media which is known as acute necrotizing otitis media. And this is the type of acute otitis media we see in children suffering from measles, scarlet fever, and influenza. I'll talk about this more in details in another session, and that kind of completes everything you need to know about acute otitis media. If you have any questions, please comment down below and I'll get back to you. Thank you.